Hello everyone. The topic for this session is spinal cord. The objectives are to learn about the spinal cord, its features, the meningeal coverings, nuclei, the laminar organization, the tracts and the clinical anatomy. The spinal cord is the cylindrical lower part of the central nervous system, and it is the main pathway for the information connecting the brain and the peripheral nervous system. It occupies the upper two-thirds of the vertebral canal and it is enclosed in 3 meninges. It gives rise to 31 pairs of the spinal nerves. So, it measures about 18 inches, that is 45 centimeter in adult male and 42 centimeter in adult female, weighs about 30 gram and it extends from the upper border of the atlas to the lower border of the first lumbar vertebra. In case of children, it extends up to L3 vertebra. Superiorly, it is continuous down from the medulla oblongata and inferiorly it continues as the conus medullaris. The spinal cord is covered by the 3 meningeal coverings. From outside to inside, it includes the dura mater, the arachnoid mater and the pia mater. So, in the dissected part, we can observe the dura mater, the arachnoid mater and the pia mater. We can observe here all the 3 are enclosing the spinal cord. So, at the level of the lower part of the first lumbar vertebrae, the spinal cord continues as a conus medullaris. So, below the level of conus medullaris, only the pia mater is continued as the filum terminale. So, the filum terminale contain only the pia mater. It looks like a thin fibrous cord. The modification of the pia mater. So, the first is ligamentum denticulata. These are 21 pairs of teeth-like projections. They fuse laterally with the arachnoid and dura maters between the axis of the roots of adjacent spinal nerves. The highest process attaches immediately superior to foramen magnum. So, the function of this ligamentum denticulatum is it keeps the spinal cord in position. So, diagrammatically we can represent the ligamentum denticulatum and the emerging the spinal nerves like this. Another modification of pia mater is linea splendens. It is a thickening seen at the anteromedian sulcus in the lower part of the spinal cord. So, one more modification of pia mater is filum terminale. It is about 20 centimeter long and after living through the sacral hiatus, it ends by getting attached to periosteum of dorsal surface of the first segment of coccyx. So, here we can see the filum terminale as a thin fibrous cord. It can be having 2 parts, the filum terminale internum, which is in the upper part and about 15 centimeter long, extends up to the lower border of second sacral vertebra. Then the filum terminale externum, it is the lower part which is outside the dura mater and attached to the first segment of the coccyx. So, in between these coverings, there will be a presence of space. The subdural space is present between the dura and the arachnoid mater. The subarachnoid space lies between the arachnoid and the pia mater, and the epidural space is present above the dura mater. So, here in this space we can give the epidural anesthesia. It is filled with adipose tissue and contains the network of blood vessels. So, the spinal cord shows two enlargements. The one is the cervical enlargement and another one is the lumbar enlargement. The cervical enlargement, it is for supplying the upper limb muscles. This extends from the C4 to T1 spinal segments with the maximum diameter of 38 millimeter at the level of C6 segment. The lumbar enlargement for the muscles of lower limb, it extends from the L2 to S3 segments. Its maximum diameter is 35 millimeter at the level of S1 segment. So, here we can make out the cervical enlargement and the lumbar enlargement. Cauda equina. So, the cauda equina, it resembles the horse tail and it consists of about 40 nerve roots at the beginning. So, the dorsal and the ventral nerve roots of right and left sides of L2 to L5, S1 to S5 and the coccygeal 1 nerves, they lie vertically around the phylum terminally. So, that gives the resemblance of horse tail. So, the 40 nerve roots includes the 16 lumbar including the right and the left, the 20 sacral and 4 coccygeal nerve root. So, at the end only the phylum terminal remains attached to the coccyx. Now, the external features of the spinal cord. Anteriorly, the spinal cord reveals a deep anterior median fissure where there will be presence of anterior spinal artery. Posteriorly, we are having the posterior median sulcus. It is a thin longitudinal groove extending from which a septum runs in depth of the spinal cord. So, each half is divided into anterior funiculus, the lateral funiculus and the posterior funiculus by anterolateral sulcus and the posterolateral sulcus. So, the ventral or the motor nerve roots emerge from the anterolateral sulcus, whereas the dorsal or the sensory nerve roots enter the spinal cord from the posterolateral sulcus. So, now the internal features. The white matter, that is the nerve fibers, lies outside and the grey matter lies inside. So, here the inside H-shaped structure is the grey matter and surrounding that is the white matter. White matter is due to the presence of the nerve fibers and the grey matter is due to the presence of the cell bodies. The central of the grey matter, there is a central canal that consists of the cerebrospinal fluid. So, this canal is lined by a single layer of ependymal cells. So, the grey matter consists of the anterior horn and the posterior horn. So, there will be a difference in the anterior and the posterior horn at different levels. So, we will see the differences at the different levels. First, in the cervical region. So, in the cervical region, when we take a section, it looks large and oval. The posterior horn is long and slender and the anterior horn is broad and massive. Actually, in the C1 to C3 segments, it is narrow but broad in C4 to C8 segments for the supply of the upper limbs. The thoracic level, at the thoracic level, it is small and circular. The posterior horn is slender and at the thoracic level we are having the extra horn, that is the lateral horn. The anterior horn is slender. So, it is slender from T2 to T12 segments, but in T1 segment it is broad. At the level of lumbar, it is large and circular. The posterior horn is bulbous and short, whereas the anterior horn is bulbous and short. So, in the sacral region, it is small and circular or quadrilateral. The posterior horn is massive and ovoid, and the anterior horn is massive and ovoid. So, this lumbar and the sacral region, that is the anterior horn is large to supply the lower limbs. The functions of the spinal cord. So, first is the conduction. The bundles of fibers passing information up and down the spinal cord. So, from the brain and again towards the brain. The locomotion, the repetitive coordinated actions of several muscle groups, and the reflexes. So, it involves the involuntary stereotyped responses to stimuli and involve the brain, spinal cord and the peripheral nerves. Clinical aspect, the lumbar puncture. It is done at the level of L4 in children and L3 in adults. So, in the lumbar puncture, the patient will be in the universal flexion position and the needle is inserted between the spines of L3 and L4 or L4 and L5. It passes through the supraspinous and interspinous ligaments and through or between ligamentum flava. So, it does not penetrate the posterior longitudinal ligament. So, once we enter the dura, it will give a sensation of give. So, epidural anesthesia. So, here in the epidural space the drugs are injected and the epidural anesthesia can be given. In the spinal anesthesia, it is given in the subdural space. Conus medullaris syndrome. So, it is due to injury to the S2, S4. There will be anesthesia in the perineal region and there will be involvement of the bladder and the bowel. The CAUDA equina syndrome, it is a lower motor neuron type of paralysis in the lower limbs due to compression of the ventral nerve roots. The root pain is an important symptom due to involvement of dorsal nerve roots. So, the bladder and the bowel involvement is late. The poliomyelitis, it is a viral disease, involves the anterior horn cells leading to flaccid paralysis of affected segment. It is a lower motor neuron type of paralysis. If there is involvement of upper cervical segments of spinal cord, it is fatal. Tapes dorsalis, it occurs during tertiary stage of syphilis. The degenerative lesions of dorsal nerve roots and of the posterior white column will be there and there will be severe pain in the lower limbs. So, now we will discuss about the spinal nerves. The spinal nerves arise in pairs. There are 31 pairs of spinal nerves, which includes the 8 cervical, 12 thoracic, 5 lumbar, 5 sacral and 1 coccygeal. So, each spinal nerve arises by a series of 6 to 8 dorsal and ventral nerve rootlets. These rootlets, they join near the intervertebral foramen to form the spinal nerve. So, the spinal nerve will be having the motor and the sensory component. Then the dorsal root ganglia. As the dorsal rootlets converge, there is a swelling called on the dorsal or the posterior root ganglia. So, here we can see the enlargement or the swelling, that is the dorsal root ganglia. So, the neurons here is pseudo unipolar type of neurons. So, the branches of the spinal nerves, after the formation of the trunk, it is divided into dorsal ramus, which will be going to the posterior aspect, and the ventral ramus emerging anteriorly. So, the dorsal ramus again divides into the medial and the lateral branch. The ventral ramus gives the lateral cutaneous branch, which gives the anterior and posterior branch, and the anterior cutaneous branch that gives the medial branch and the lateral branch. So, spinal segment. Spinal segment are a part of the spinal cord. Here it is the segment where there is a pair of dorsal nerve roots, both right and left side, and a pair of ventral nerve roots is attached, is called the spinal segment. So, here we can observe the anterior rootlets and the posterior rootlets. So, both right and left side includes in one spinal segment. So, the level of the spinal segments varies because the vertebral column length is more, but the spinal cord length is less. So, according to the number it won't coincides. So, here in this table we can observe the vertebral level at C1, C7, the spinal segments corresponds to that level is C1 to C8. So, when we observe all these things, all the spinal nerves except C1 to C8 exit below their corresponding vertebrae. The nerves C1 to C7 live above the corresponding vertebrae. The C8 nerve lives below C7 vertebra. So, the level of the spinal cord also varies depending upon the age also. In fetus, the conus medullaris lies at the level of S2, whereas during birth it will be at the level of L3, and in adults it is at the level of L1 or L2. The spinal dura mater is the same in all three stages, that is at the level of S2, and during adults the subarachnoid space is at the level of S2 segment. So, the nuclei of the spinal cord. The grey matter of the spinal cord is arranged in 3 awns. The anterior awn, which is motor in function, the lateral awn, that is including the visceral efferent and afferent in function, and the posterior awn, which is sensory in function. So, in each fasciculi there will be the arrangement of the different nuclei. So, nuclei in the anterior grey column. The anterior grey awn, that anterior awn, it is divided into the ventral part, the head, and the dorsal part are the base. So, here we can observe the distribution of the nucleus on the ventral aspect, dorsal aspect, and in the central aspect. So, the nuclei in the anterior awn, it innervates the skeletal muscles because it is motor in function, we have seen before. So, most prominent neurons are the alpha neurons, and the smaller neurons are gamma neurons. So, these supply the intrafusal fibers of the muscles spindles. So, here the cells are arranged in different groups. The ventral part, it innervates the skeletal muscles. The three main groups are the medial group, it presents throughout the extent of the spinal cord and innervates the axial muscles of the body. It includes the ventromedial and the dorsomedial groups. So, in the ventral aspect, it is concerned with the motor function and the nuclei arranged in the two groups, the ventromedial and dorsomedial. The lateral group, it includes the cervical and the lumbar enlargements. So, in this area we can see the lateral group. It supplies the musculature of the limbs. It includes anterolateral that supply the proximal muscles of the limbs like shoulder and arm and the gluteal region and the thigh. Posterolateral, it supplies the intermediate muscles of the limbs, that is forearm and the leg. And the posterolateral innervating the distal segment, that is hand and the foot. The central group only in the cervical segments presents as the phrenic nerve nucleus and the nucleus of spinal root of accessory nerve. So, now nuclei in the lateral grey column. It includes intermediolateral nucleus which acts as both efferent and afferent nuclear columns. So, it is seen at two levels, T1 to L2 segments. It gives rise to preganglionic sympathetic fibers. So, it is known as thoracolumbar outflow. Another one is S2 to S4 segments that gives rise to preganglionic parasympathetic fibers. It is chiefly for the pelvic viscera. So, another group in the lateral grey column is intermedial nucleus. So, it includes internuntial neuronal columns. So, nuclei in the posterior grey column, there are four main afferent nuclei are seen in this area. So, when we observe, we have seen the posterior on is the sensory and the anterior on is the motor. So, in the posterior grey column, we are having the four main afferent nuclei. One is the postromarginal nucleus. It is a thin layer of neurons caps the posterior horn. So, here we can observe the cap like structure in the posterior horn. It receives the incoming dorsal root fibers. The substantia gelatinosa, it is found at the tip of the posterior horn through the entire extent of the spinal cord. So, here there will be presence of first order neurons of lateral spinothalamic tract synapse. Next is the nucleus proprius. It lies adjacent to the substantia gelatinosa. It extends throughout the spinal cord. The dorsalis nucleus or the nucleus dorsalis of Clark, also known as the thoracic nucleus. It extends from C8 to L3 segments. It contains the interneurons. So, in the laminar organization of the spinal cord, in the thick sections, the spinal cord neurons appear to have a layered arrangement that is called the laminar arrangement. So, 10 layers of neurons are recognized. They are also known as laminae. So, they are numbered by the Roman numerical starting from at the tip of the dorsal horn and moving towards the ventral horn. So, laminae 1, 2, 3 and 4 are concerned with exteroceptive sensation and comprise the dorsal horn. The laminae 5 and laminae 6 are concerned primarily with the proprioceptive sensations. Lamina 7 is equivalent to the intermediate zone and acts as a relay between the muscle spindle to midbrain and cerebellum. The laminae 8 and 9 comprises the ventral horn and contains mainly the motor neurons. The axons of these neurons innervate mainly the skeletal muscle. Laminae 10, it surrounds the central canal and contains the neuroglia. So now sensory receptors. So the peripheral endings of the afferent fibers receives the impulses, they are known as the receptors. So it includes exteroceptors. It responds to the stimuli from external environment, that is pain, temperature, touch and pressure. Proprioceptors, this responds to the stimuli in deeper tissues. For example, contraction of the muscles, movements, position and pressure related to joints. So these are responsible for coordination of muscles, maintenance of the body posture and equilibrium. So these actions can be perceived both at the unconscious level and at the conscious level. Then another one is the interoceptors or enteroceptors. It includes the receptor end organs in the walls of the viscera, gland, blood vessels and specialized structures in the carotid sinus, carotid bodies and osmoreceptors. It carries the sensation of hunger, nausea and pain also. Special sense receptors, these are concerned with vision, hearing, smell, balance and taste. So these are the four main functional classification of the sensory receptors. Now the tracts of the spinal cord. So tract is nothing but a collection of nerve fibers that connects the two masses of grey matter within the central nervous system. So it may be ascending tract and the descending tract, that is the ascending one which is going towards the brain and descending tracts is one coming from the brain. Some of these tracts also called as the fasciculi or the lemnisci. So the descending tracts, it may be pyramidal tracts or the extra-pyramidal tracts. The pyramidal tracts includes the lateral corticospinal tract and the anterior corticospinal tract. The extra-pyramidal tracts includes rubrospinal tract, medial reticulospinal tract, lateral reticulospinal tract, olivospinal tract, lateral vestibulospinal tract, tectospinal tract and the descending autonomic fibers. So these are the descending tracts which comes under extra-pyramidal tracts. So the location of the descending tracts, so in the section we can observe the rubrospinal tract, the lateral reticulospinal tract, the lateral corticospinal tract. So that will be in the lateral funiculus. Then the medial reticulospinal tract, tectospinal tract, vestibulospinal tract, so what are the functional significance of this? The cerebral cortex controls the gross and fine skilled voluntary movement of the opposite half of the body through anterior horn cells. The facilitatory for flexors and inhibitory for extensors. The anterior corticospinal tract controls the voluntary gross movement. It facilitates the superficial reflexes and the muscle tone. The basal ganglia and cerebellum are mediated by corticospinal tracts. So now the ascending tracts, it includes lateral spinothalamic, anterior spinothalamic, fasciculus gracilis, fasciculus cuneatus, dorsal spinocerebellar, ventral spinocerebellar, spino-olivary and spinotectal. So, location of the ascending tracts, we can observe the fasciculus gracilis, fasciculus cuneatus, the ventral or the anterior spinothalamic tract, lateral spinothalamic tract, dorsal or posterior spinocerebellar tract, the ventral or anterior spinocerebellar tract, spino-olivary tract. So, when we observe the lateral spinothalamic tract, the ventral or anterior spinothalamic tract and the anterior spinocerebellar tract are having the crossed fibers to the opposite side. So, the functions of the ascending tracts. Lateral spinothalamic tract is concerned with the pain and temperature from opposite half of the body. Anterior spinothalamic, touch and pressure from opposite half of the body. Fasciculus gracilis and fasciculus cuneatus concerned with conscious proprioception, discriminatory touch, vibratory sense and stereognosis. Posterior spinocerebellar concerned with unconscious proprioception from individual muscles of lower limb. The anterior spinocerebellar concerned with the unconscious proprioception from the lower limb as a whole. Spino-olivary proprioceptive sense and the spinotectal afferent limb of reflex movements of the eyes and head. So, now we will observe the comparison between the upper motor and the lower motor neuron paralysis. In lower motor neuron paralysis, the muscle tone is abolished. In the upper motor neuron paralysis, the muscle tone is increased. The LMN paralysis leads to flaccid paralysis. The UMN paralysis leads to spastic paralysis. The muscles atrophy is later in LMN paralysis. No atrophy of muscles in UMN paralysis. Reaction of the degeneration is seen in LMN paralysis and the reaction of degeneration is seen in the upper motor neuron paralysis. Tendon reflexes are absent in LMN paralysis. It is exaggerated in UMN paralysis. Limited damage in LMN paralysis. The damage is extensive in upper motor neuron paralysis. In LMN paralysis is ipsilateral. Most of the time the UMN is contralateral. The Babinski sign is negative in LMN paralysis. The Babinski sign is positive in UMN paralysis. All superficial and deep reflexes lost due to damage to motor pathways. Superficial reflexes like abdominal, cremasteric, plantar are lost due to damage to corticospinal tracts. The LMN paralysis may affect single muscle group as in poliomyelitis. It affects many groups of muscles as in hemiplegia. So, now the blood supply of the spinal cord. The spinal cord receives its blood supply from 3 longitudinal arterial channels that extend along the length of the cord. The anterior spinal artery is present in relation to anterior median sulcus. 2 posterior spinal arteries run along the posterolateral sulcus. So, in addition to these channels, the pia mater covering the spinal cord is having an arterial plexus called the arteria vasa corona that sends the branches into the substance of the cord. And also it is supplied by the anterior radicular artery, the posterior radicular artery, which are branches from the segmental artery. So, these radicular arteries arise from the spinal branches of vertebral, ascending cervical, deep cervical, intercostal, lumbar and sacral arteries. So, in this diagram we can observe the vasa corona, which is present in relation to the pia mater, and we can see the branches that will supply the substance of the spinal cord. The venous drainage, it is by median longitudinal venous channel, which is present at the anterior fissure, and the posterior median longitudinal venous channels, and also it consists of the posterolateral and the anterolateral longitudinal venous channels. So, all these 6 veins drain the spinal cord. So, they are arranged in a longitudinal channels. So, these channels are interconnected by plexus of veins that form the venous vasa corona. So, from there it is drained into the radicular veins that opens into venous plexus lying between the dura and the vertebral canal, and through it enters into the various segmental veins. So, clinical aspect, the anterior spinal artery syndrome. The anterior spinal artery supplies the anterior 2/3 of the spinal cord. So, thrombosis of this artery leads to loss of tracts and the loss of motor neurons in the anterior 2/3 of the spinal cord. That results in motor loss due to involvement of motor neurons in the ventral horn of the spinal cord. So, that leads to the anterior spinal artery syndrome. The posterior spinal artery supplies the posterior 1/3 of the spinal cord, and if it gets affected, then it causes the posterior spinal artery thrombosis. So, the tracts and other ascending and descending tracts we will discuss in detail in the next class. So, now the questions for the assignment. The transverse section of the spinal cord showing ascending and descending tracts. Give the termination of spinal dura mater and the pia mater. Typical spinal nerve. Sensations carried by posterior column of the spinal cord. Blood supply of the spinal cord. So, we will have case scenarios. The first one, a 7-year-old boy has been having high grade fever for 5 days. One evening he is complained about weakness in his right lower limb. Soon he could not support the body. So, what is the probable diagnosis? Which part of nervous system is affected? What type of paralysis is it and what are its features? Second case scenario, a young person is involved in an automobile accident with injury at cervical 5 and 6 vertebrae. He develops paralysis of all the 4 limbs. What is the type of paralysis? Mention the symptoms. What are the differences between upper motor neuron and lower motor neuron paralysis? Thank you.